this ronger unfortunately hit the artery at the back of the spinal cord. So with no surprise, this patient was wheeled to theatre again for an emergency laparotomy by a general surgeon at the center. And the aim was to stop the exsanguinating bleeding and, of course, to save the patient's life. Therefore, a primary repair of the right CIA was done, and the patient was brought out of theatre uneventfully after that. However, post-operatively, the problem did not end there. The patient started complaining of right lower limb numbness and pain. So when she was examined further, it was noted that the pulses at her right lower limb were diminished with monophasic Doppler signal still present, with the ankle brachial systolic index of 0.7, indicating some form of ischemia in that limb. So at this level, further physical examination also revealed that this is 1 week after the post-operative period. The general examination revealed that she was edematous, she was breathless, she had ascites with bilateral lower limb swelling, reduced effort tolerance, and the lower limb examination remained unchanged. So to tie things together, she basically was presenting herself with the symptoms of heart failure. So again, moving forwards, what could have happened that she now has a heart failure? The general examination revealed that she was edematous. So when she was referred to a tertiary center, a proper CT angiography was done. And this is what we found. As we walk through the CT, we can see that both the aorta and the IVC are lighting up. The IVC is bigger in caliber from the usual size. As we move downwards, we can see both the great vessels lighting up. As the aorta bifurcates, we can see that as the aorta bifurcates here, we can see that there is a fistulation of the common iliac artery and the iliac vein. And then it reconstitutes from pelvic collaterals, and the external iliac artery lights up again. So to conclude, right CIA and left common iliac vein fistulation, short segment thrombus in the common iliac artery on the right side, good collateral flow in the right external iliac resulting from pelvic collaterals. That was the fortunate bit for this patient. So what left common iliac vein. So at this point of time, we had a goal to achieve. Our treatment goal was to mitigate or to treat the heart failure rather than to deal with the diminished pulses at the lower limb. Because the lower limb was not threatened, it was surviving by collateral circulation. And the main problem for that patient at that point of time was the heart failure. So we were at a juncture to decide on what modality are we going to use to treat that heart failure. We had two options. We could have brought the patient in for an open repair, or we could have done an endovascular procedure in the angio suite. After a lengthy discussion and multidisciplinary discussion, we decided that this patient will fare better with an endovascular approach. Why is that so? If we were to look at open repair, of course, it's a more durable and straightforward thing to do, to bring the patient into theatre, put our clamps on, repair the fistulation, and repair the artery with either a bypass or a primary repair. But the challenges at that time that we were facing is that the patient factor, the patient was having heart failure and she just recently had a surgery. She was very, very depressed, and she was threatened that her condition is going to get worse. Besides these patient factors, we also had limitations in the sense that we were facing a pandemic at that time. Our theatres, our operating times were limited. Therefore, putting all this together, we decided that the patient goes for the endovascular option. So what was our aim our aim still remained the same, was to treat the heart failure, but what options did we have and how are we going to achieve that is that we thought of either stenting the fistulation or performing an embolization of the fistula to mitigate or treat the heart failure. And these are the things that we had in store to deal with that. The challenges for that is that, of course, the technical bit of it will be narrated by Dr. Nick on passing the wires through for a stent placement, or why did we actually embolize the patient later on. So for this bit of the presentation, I will pass it over to Dr. Nick. And then later we'll continue on discussing a bit more on this condition. Thank you.
Okay, we'll go into our second speaker. Dr. Ni Azwan is a general radiologist and interventional radiologist in Hospital Chancellor Tuanku Muhriz. He graduated in 2003 in National University of Ireland, Galway, and he had his Master of Radiologist in 2011. He has numerous publications under his belt and have done some clinical attachment in various countries, including Korea and Hong Kong. Okay, Dr. Ni Azwan.
All right, thank you very much, Ms. Lenny, for the kind introduction. Can see my slides? All right, and thank you, Mr. Kishan, for the laying out the foundation. My name is Ni Azwan. I'm one of the interventional radiologists in our hospital. Just a brief summary of what we do. Okay. So basically, we have an angiography unit in the radiology department at the ground floor. This is properly established in 2011 with the introduction of a clinic. We are also known as iMagic, Image Guided Intervention Center. We are doing about 2,000 plus cases per year. And this is one of the angio room. We have two machines. This is a biplane machine, which is mostly used for neurovascular cases. And this is the other angio room, which is quite special because it is called a hybrid angio, whereby HEPA filters are placed inside so that it is used as a proper OT setting. So this is where we conduct the sterile cases and also in the open repair with the vascular team. All right, so straight to the cases as mentioned before by Mr. Kishan. So this is the latest CTA performed prior to the intervention that we do. So we have in axial cut in the pelvic region of the plain, arterial, and venous. And then Mr. Kishan already explained quite excellently. So what we do have is an iliac cable fistula. So the thing is we need to close off the communication there. So this is reconstructed images from the CTA that I showed earlier. So as you can see, there is a stump of the right common iliac artery in communication with the distal inferior vena cava. All right, so the IVC is light up early, and then there is no communication with the distal right common iliac artery. However, reconstruction are noted beyond that. All right, so an angiography was done the day after the CTA was performed here at our center. So this is a more real-time dynamic, so we can see the flow. So the catheter we came from the the left brachial artery. The cut down was performed by the vascular team, and from there, we put in a catheter, a 6 French catheter via the left brachial artery. The open cut down was performed to reduce the complications such as hematoma and for easier manipulation of the large catheter. And this guider, from there we put in a catheter. Because of the shape, we call it a pigtail catheter, the famous pigtail. So from there we injected contrast, and then we, as I shown earlier, we see the aorta, right common iliac artery, ossification, and then straight into the IVC. All right, and then so we have an illocable arteriovenous fistula, whereby there's diversion of blood flow from the higher arterial flow to the lower venous circuit. So what happened, as explained by Mr. Kishan, there's decrease in the total peripheral resistance because there is a bypass of the flow, causing increase in the venous pressure and blood volume, resulting increase in heart rate, stroke volume, and cardiac output. So more or less what we have is a high output cardiac failure. All right. So looking at the CT, we need to see the complication of this fistula. So as you can see the measurement here, the ratio, the heart is enlarged with the cardiomegaly, and there's also evidence of fluid pooling in the third space, yes, in the pericardial space as well as in the pleura. So at the same time, because we have a problem with the cardiac output, number one. Number two, we also have problem with the occlusion. So we need, from the CTA, we need to determine the complication of that. So from the CTA, we can see there is reconstitution of the distal vessel towards the limb. And from the axial CT, you can see the external and internal iliac arteries bilaterally light up. So there's enhancement, so it's patent. And then lower down, we can see the superficial femoral artery on the right and on the left are also patent. So the limb are not really compromised. All right, so as mentioned by Mr. Kishan, what's the option? We can do a covered stent. So basically like a bridge, bypassing the bridge disconnection between the occluded part. So basically covered stent basically is just an internal metal or mesh covered with the PTFE graft, so that there is no blood, so that blood can flow through this graft. Another thing is we can close off the vessel or the stump of the common iliac artery altogether, because there is reconstitution of the distal vessel to the limb, so, and the limb is not threatened. So briefly, embolization is a minimally invasive treatment to occlude arteries or veins. On the arterial side, we can close off the arteriovenous malformation. We can treat the arteriovenous fistula, such as in this case. On the oncology or tumor part, we can just use blend embolic agent for treatment of uterine fibroid, benign prostatic hypertrophy, and or we can combine that embolic agent with the chemo drugs or radio therapy for embolization to treat cases such as hepatocellular carcinoma. We can do embolization for preoperative, for example, in spinal tumor, intracranial tumor, so that the surgeons have minimal bleeding during the operation. And we also use embolization to treat bleeding vessel, for example, in traumatic cases, MVA, in cases like a GI bleed, if the surgeons unable to control the bleeding via colonoscopy. So embolization will be a second line of the treatment. Treatment of aneurysm, be it intracranial or peripheral, or venous malformation, treating of the varices, varicocele, all can be done via endovascular. All right, so as discussed earlier, what are we going to use? All right, so the patient, from the discussion, we can use either a stent graft or we can close the common iliac artery itself, the stump. So the plan is we're going to come from the left brachial artery, bringing the catheter and guider down, and then we're going to try to cross the lesion if it's possible. But looking at the CTA, the chances of crossing looks quite slim because the distal stump looks quite blunt. There is no, so blunt means that probably it's already closed off or sutured off. So unlikely we can cross it lah. So during the operation, we tried to cross but unsuccessful. So we decided to go for the embolization. All right. So what we do is from the guider, we introduce the catheter. We do a run just now from the picture catheter. And using that image, we bring in the, this is one of the embolic device that I will mention, I will describe later. It's called a vascular plug. So basically, it's just a nitinol mesh, which is being packed inside the vessel. All right. So this is a post. This is during deployment, just to check. So we did close off the stump. All right, and then we can see the distal right external and internal iliac artery are patent. Supplies are quite numerous from the lumbar arteries and also from the pelvic vessels from the contralateral side. And then we didn't include the flow to the contralateral limb to the common left common iliac artery. All right. So as I mentioned before, the embolic agents are various type of embolic agents. So just to divide them into two main categories, which are the temporary and the permanent one. Temporary is to occlude the vessels for a few days up to a few weeks, and permanent is the embolic agent will stay there forever. All right. So basically, for the temporary, we have the gel form and we have the thrombin as well. It causes coagulation of thrombus. We do have a permanent type as well, which consists of particles, PVA, embospheres, coils, mostly are metals. This is pushable, injectable, detachable is the way we deploy the coils. And then we have the liquid agent, so-called glue or histoacryl. And then we have the liquid embolic agents such as Onyx, Squid, and a few other brands. And then the one that we are focusing will be the unplugged plugs. We also use as detachable balloons in cases for the intracranial CCF, cavernous fistula. All right, so this the temporary agent. So basically, it's the one on the left screen will be the gel form, which is also used in OT. So what we do is it's made of a gelatin. So basically, we just cut it into small particles, and then we mix with the saline and make it into a slurry. Thrombin can also be used for treatment of pseudoaneurysm. All right. And then this is the particles that I'll talk about, the PVA, polyvinyl alcohol in powdered form, or the latest form will be the microspheres, which is more consistent. The size is varies. So the usual size will be about 300 to 500 micrometers. And then these particles are delivered via the catheters into the vessels, and then we inject it to the tumor. So this usually we use for treatment for tumors, for target vessels and GI bleed, things like that. We also have coils, metals that is pre-shaped into certain shape. So bare metal, fibered metal. Fibered is to promote thrombosis. So for the treatment of aneurysm in the brain or elsewhere. This is the famous glue, which is actually is a histoacryl. This is, we combine it with the lipiodol, which is a contrast agent. And then this mixture is used to close off the bleeding vessel. Another newer type of liquid embolic agent will be so-called like Onyx, Squid, Field. These are much more easier to control, and then the flow is, the user experience is much better, but it's quite costly because 1 ml of this costs about 2,000 plus ringgit. So mostly sometimes we use it in the intracranial, in the brain. For example, in this case, this is a atriovenous malformation of the brain, whereby we have to close off the AVM itself. So back to the case. So what we use is a plug, a vascular plug, which is a self-expanding devices made of nitinol wire mesh. So basically, the main aim is to stop the flow, various type of AVP and from various companies. The one that we use is called the AVP2. Basically, it's same as a single AVP, but it has another 2 smaller ring besides it, so that it better blockage of that flow. So we put in the vessel and then we just leave it there. All right, so the advantages will be you can use it in the medium to large vessel with a high flow, such as in our case in the iliac vessel. And this one plug can substitute or we can replace it. Otherwise, we have to use multiple coils to close off the vessel, which is much more cost effective. And by using this, nowadays we have a lower delivery device, so it's easier to use. We can see in the X-ray with the good already opacity. And some plugs can even be delivered using diagnostic angiographic catheters, such as what we did. It's easy to use. Technical success about 92 to 100%. There is risk of recardinalization, 0.4%, device migration and embolization. So that's why in this case, what we did is we really packed the vascular plug close into the stump. And then so that you have to ensure that there is no risk to the contralateral limb. And then also ensure that there is good collateral supplies to the distal vessel that we are closing off. All right. And then I think with that, I thank you.
Okay. We'll continue with Dr. Kishan.
Thank you, Dr. Nick, for the elegant presentation. I will continue now by just looking at a few literatures, and we can discuss on the long-term outcomes, and we're done. Okay, so by now, what should we have already known about this kind of condition? So if we look at literatures, some papers that I came across, this Taiwanese paper highlighted a case whereby they ran into a similar situation, but they were on a tough ride because the patient exsanguinated quite badly on table, and subsequently the patient had to be, because the patient was in a prone position, had to be switched, and they performed an emergency laparotomy, a primary repair, and thankfully the patient survived. So this is just to show that another option that if it is picked up immediately, then an emergency laparotomy would have been warranted, and a proper repair would have settled the problem at that juncture itself. This Greek paper, what they have done on this paper is they have reviewed close to about 2,000 cases of similar presentation, which is aortic cable injuries after lumbar disc surgery. And they found that there were multiple ways of dealing with this problem, i.e. Emergency laparotomy and primary repair, a bypass, stenting or embolization like what we have done. And they have found that in long run, up to 6 years of follow-up, most of these patients actually did quite well in the sense that, the bleeding was tackled, of course, immediately, and the long-term complications from this injury was avoided. And this paper by the European Journal of Vascular Surgery, a French paper, highlighted the use of stents in this kind of conditions, where in this particular patient, a wire, as described by Dr. Nick, was able to be passed beyond the target site, the target lesion. Therefore, a stent was deployed. So they achieved two things. One is to restore flow into the thrombosed artery, and also plugging the fistula, and therefore reducing the or treating the heart failure. And this is our very own publication regarding this case that we have published using Vascular Plug. So in summary, aortoiliac artery injury post lumbar spine surgery is an unusual presentation. As quoted by this Greek paper, the incidence is about 0.02 to 0.06%. And it may present early or late with varied presentation. This is what I wanted to stress upon. If it is picked up early, as in if the patient is having a torrential bleed, obviously it will be picked up early. But bear in mind that these patients can also present later with symptoms of limb claudication or heart failure, because the injury was not so pronounced. So the fistulation had occurred, and over time, the patient will present to us with either claudication symptoms on the lower limb or symptoms of heart failure. L4, L5 being the most susceptible level for injury because of the close relations of the artery just behind this level. This is just a recap on anatomy and available modalities. So if we are in a center with various modalities, I mean, it is good to know what are the options we have in treating a patient. And when treating a patient, it is important to have a clinical goal. In this patient, we were clear that our primary aim was to treat the heart failure, and thankfully we managed to achieve it. So having done that, what are the long-term concerns that we have for this patient? Now it is about a few months down the line. We've seen her in the clinic. She's well. Her heart failure is completely resolved. She's happy with the quality of life. But that's just 6 months down the line. What are the things that we should look out for? And in years to come, as she is still a young lady. So for that, we will have it in the Q&A session and discussion. I pass it back to Ms. Lenny. Thank you.
All right. Thank you, Dr. Kishan and Dr. Ni Azwan. So basically, when we have these patients, that's two main issues, which is a heart failure and also the right lower limb that end up chronic limb ischemia. I mean, being young, we are quite lucky because collateral developed very fast and good enough until she doesn't have any claudication. So when we have these patients, our aim, the first aim is of course to close the fistulation, which actually is the culprit of the cardiac failure. Okay, talking about open surgery, frankly, in good hands also are the two main things that if I'm the vascular surgeon, I would think of about is the recent surgery. It's cost addition. I think no surgeon would like to operate in a recent surgery. And number two, knowing the anatomy of IVC, and then the fistulation also is really at the bifurcation IVC to the iliac veins. It's something difficult. So if let's say one of the options, if let's say we need to do an open surgery, maybe I will just ligate the right common iliac artery and reassess patient. Okay, so if let's say patients having chronic limb ischemia, that means a recon work need to be done. So it's either ITO by FEM. Okay, of course, FEM crossover is not an option since patient is very young. And when we talk about FEM crossover, we are talking about patency rate, which will be very low. Okay, all right. Other than this, talking about endovascular, we have seen various method, various product that used as to embolize. Okay, but in this case, we know that number one, we are dealing with medium to big target vessel, and number two, we are dealing with a high flow fistulation. So of course, we don't want to use anything that can cause embolization. So AVP is a good product that's suitable and is easily delivered. So actually, we managed to do the patient under sedation only, not even under GA. So because the case was done during our COVID was at the peak, so we don't have ICU bed. So basically, this AVP have helped the patient. Okay, so at least we settle. So currently, patient is under our follow-up, managed to stop Lasix and also beta blocker. I think water retention is totally, ascites also disappear. So we are monitoring her claudication distance. Her ABSI is 0.8. So if let's say she's getting more active and she has claudication, so we need to address the issue later. All right, I think we can open to Q&A.
There is a question by Prof. Andrea Ban. In the chat box.
Oh, okay. Lumbar puncture procedure. I think because lumbar puncture needle is quite small. Usually once you puncture artery or vein, it will develop clot first unless patient is coagulopathy. And then talking about IVC and aorta, God is great. It's created retroperitoneally. So I think most of the case, the bleeding just stopped by hematoma. Dr. Nick, any
I do agree with Ms. Lenny. Basically, for the lumbar puncture, the needle is quite small, and then we usually is easily tamponade off. We do in the difficult cases. Sometimes we do biopsies or via the IVCs, but not by the aorta. But via the IVC is quite. We can perform it, and then it is seal off quite easily lah. Of course, for the aorta or arteries, we don't dare to do that lah, because of the bleeding risk. Yeah. Otherwise, I just want to touch a bit more on the embolic device. We need to look at the type of the embolic device that we use as well. For example, for in this case, like mentioned by Ms. Lenny, the vessels, the common iliac vessels are big, about 8 mm to 1 cm in diameter. So, of course, liquid agent is not suitable because it will fly off. The coils itself, we can use coils, long coils, which are available. But the same thing is a high flow, it can easily push the catheters into other vessels as well. So, and then the cost of the long coil is about 2K as well, which is similar to the price of this AVP, so that the ones that we use just now. So what we do is we just have to ensure the sizing are correct. So basically that CTA and the angiogram really helps. So and then once we have the sizing of the target vessel, we just upsize the size of the vascular plug so that we have a good good occlusion of that vessel to make sure it doesn't migrate.
Okay, there's a question from Dr. Patrick. Is it possible to go retrograde from tibial artery for wiring into the iliac artery? This case actually, somebody has attempted wire through right common iliac, which cannot go through. So most likely it's totally occluded. So talking about going through the left side, because the delivery system of the AVP is quite stiff. So when we need to angle to the right side, I think it's quite difficult. So we decided to go through brachial because this patient partly the problem the artery is quite small. So the brachial artery was 3 mm. So obviously we cannot do it percutaneously. So we decided to do it open. So I think from the left brachial artery is more straight. So that's how we come into the decision of Asaf to take the left brachial artery.
Yes, for the delivery of that vascular plug, we need to use at least a 6 French to 7 French guider. Guider is a big catheter. So, like mentioned by Ms. Lenny, so 6 French translate to about 3 mm. So it's a very tight fit. So that's why open surgery was performed to access the brachial artery itself. The tibial artery is quite small. Usually the size is about maybe around 2 to 3 mm. and we also doesn't want to compromise the precious leg as well. So that's why we decided to came from the other side. Sorry, from the above.
Dr. Nick, there's a question about the cost of EVP and other embolic agent. Is there any charge difference between emergency and elective case? Maybe you can quote, including the public and also the private rate.
Basically, the cost itself. It depends on how many or how much do we use the what do you call it, the embolic agent. The vascular plug costs about nearly 3,000 ringgit. Long coils cost about nearly that much as well, about 2,000 plus lah. So usually once if we gonna coil, we need to make sure we pack the vessels properly. So usually we need to use about 3 to 4 coils. So at least kalau 2.5 times 4 is already 10K compared to what we used just now. Liquid agent, as I mentioned before, is not applicable in this case, but depends on cases. We do use it at time. For example, in GI cases, we use it we use glue, histoacryl, in combination with lipiodor. The lipiodor itself is quite expensive, about 1,000 ringgit plus per vial. So we are talking about maybe around 1,000 to 2,000 if cases like GI bleed, things like that.
So I think compared to open surgery, obviously in open surgery, the cost will be more because there will be the need of blood products, more blood products, prolong hospital ICU stay, and also prolong ward admission. So I think it's more economical in endovascular rather than open for in this case. Okay. I think there's no more question. With that, I pass back to the organizer.
Okay, kita akan mulakan dengan kahut untuk undergrad. So gunakan nombor matrik. Terima kasih. Okey, barcode ni untuk doktor saja gunakan apps MMA. Okey, untuk doktor saja gunakan apps MMA. Link yang saya kongsikan tu semua kena isi. Semua kena isi panelis, student, staff, semua kena isi link yang saya kongsikan. Terima kasih. you.